Welcome to the Better Care National Priorities session on the role of data at the front line of the COVID-19 response. I'm Simon Ball, and I will co-chair with Alistair Denniston, one of my colleagues here in Birmingham. The Better Care programme's vision is that patients will benefit from healthcare decisions that are informed by large-scale data and advanced analytics to really identify what will work best for them. In short, it's Health Data Research UK's perspective on the development of learning health systems. Its measures of success are stated as including safe, effective, patient-centred, timely, efficient and equitable healthcare. And you might think that these are perhaps axiomatic, but they do make the point that an important driver for the programme will be how much benefit we can realise by undertaking well-conducted research. It doesn't have to be the most novel or groundbreaking, but meticulous and highly relevant to care delivery. This, of course, is all in the context of ensuring optimal use of resources, a real challenge in the context of COVID-19. Certainly my landscape looks significantly different to that in February. Beds, theatre space, outpatients, they all look different. So what does better care look like when you tear up the rule book on, for example, face-to-face consultation? A rule book that was not really a set of rules, but rather of historical conventions. So on this subject, we have asked our three excellent speakers to focus upon the delivery of better care in the context of COVID-19. Liz Sapey, Ben Goldacre and Sue Mason will talk for 10 minutes, and we'll then have an opportunity for the following 10 minutes when we can address the questions that you ask through the Q&A function by myself and Alistair to the speakers. We'll be monitoring this throughout the course of today's session. Finally, Alistair will wrap up in time for your break and to move on to the excellent sessions 7 and 8. So if I could then hand over to my colleague Liz Sapey to provide the first presentation. Liz.
Thank you, and thank you very much for the opportunity to talk to you about how the work of Pioneer pivoted in the COVID crisis to try and help frontline staff. Next slide. So acute care is any unplanned healthcare contact. And as you can see from the diagram, patients can access this from a number of different providers: pharmacy, primary care, hospital settings. And these are all interwoven as patients may traverse one service to another to gain the diagnosis and care that they need. But just because a patient might traverse services and move between them, unfortunately, it doesn't always go. In fact, it rarely goes. The data flows with them. And this creates a number of significant challenges for patients. A lack of clarity for what they've been on, what tests they've had done, results not being shared, a lack of joined up thinking. And unfortunately, this too often leads to diagnostic delay, health inequalities and poor health outcomes. So this is a sector in vital need of research and innovation. But unfortunately, it's also one of the toughest nuts to crack to gain this innovation. And that again reflects the siloed nature of data between these institutions and organizations, and a lack of clarity about what data there was. Next slide, please. So Pioneer was tasked to bring these data sets together from primary care, out-of-hours services, ambulance and secondary care, and the community care that also can be provided acutely. And hopefully, by joining these data together, understand that healthcare journey for the first time in full. The West Midlands was chosen because of its large population, its diverse demographics, and because of the number of hospitals it has. But a key feature of the West Midlands was the maturity of the digital healthcare record that the Queen Elizabeth Hospital and UHB holds. And this was put into sharp focus as COVID hit us. Next slide, please. As a frontline clinician working in the admissions unit of the Queen Elizabeth Hospital, I can't tell you how challenging and frightening it was as patients started to come in. Not only frightening for our staff and the concerns they had about their health, but real concerns about how they could care for the patients in front of them. This was a novel virus. We had no experience of it. So everybody felt that their clinical compass was off. Because of the heterogeneity in presentation, course and outcomes of patients, a lack of clarity about who had COVID and who didn't, who was hot or cold, and the lack of community testing, we really didn't feel that we were equipped as fully as we could be to look after our patients, especially since there were no proven treatments or treatment pathways. So at UHB, we considered within Pioneer that there were two urgent needs. The first was to reconfigure our hospital to account for the care needs of patients whilst protecting staff, and also a need to collect high quality data to inform our patient pathways. And the next few slides I'm going to show you are how we rapidly adapted our electronic health record and systems in order to account for this. Next slide, please. This is a still from our COVID-specific clerking sheet that was embedded quickly into our electronic health record. And this, as all the slides I'm going to show you, have made up patient data in them. So these aren't real cases of patients, but they are representative of the patients we saw. We knew that we would see a high number of patients coming through with suspected COVID, and there was certain information that we needed to collect quickly. First of all, whether or not COVID was suspected, what their duration of symptoms were, how severe they were, and then information quickly gathered to help with escalation decisions, such as decisions whether patients needed to be afforded intensive care treatments or whether that wouldn't be in their best interests. And we wanted to capture this in a structured format so the data was easy to use as a clinician and easy to understand as an analyst. Next slide, please. The last thing you saw on that clerking sheet was whether a patient was suspected or not. And this was date and time stamped, so we know when a COVID swab was sent. And this was then affiliated with our ability to identify patients as their swabs became positive, shown by the B symbol you can see highlighted. What we were able to do then is rapidly assimilate all of the positive patients against those that were suspected flowing through our hospital, where they were in the hospital, and the numbers that were coming in. Next slide, please. We're also using treatments in a different way than we had before. So in our hospital, it wasn't standard practice to offer high flow oxygen or CPAP on standard wards. There were designated areas for this with specific expertise. But we wanted to be able to capture how we were using things like high flow nasal oxygen and the outcomes associated with it. So how that would map to changes in physiology, SUS and NEWS2 scores. So this was captured with the electronic health record, as you can see, as well as the physiological information that would be needed to see what the response to this new treatment was. Next slide, please. We also recognized that there were an increasing number of potential biomarkers in COVID, and we wanted to understand their utility. But we also recognized that if you left it to the individual clinician or healthcare provider at the front door of our hospital to individually request each blood form, things would be missed off. So we created a COVID blood bundle with some of the markers you can see here measured, meaning that we were collecting this data quickly and efficiently for all of our patients. By clicking on this and clicking on the patient's name in the record, this would automatically generate labels that would be made, sent to our phlebotomists who could go and take our samples in a timely fashion. Next slide, please. We also recognise that with a change in service and the increasing numbers of patients coming through our front door, we had to think about giving care in a way that was sustainable and resilient. For example, with the high number of patients being admitted to intensive care, we were aware that there was a possibility of running out of syringe drivers that we often use for end-of-life care. At UHB, we have a structured prescribing system where it is able to propose a number of medications for you, which can then be authorized by the clinician. These have inbuilt safety checks in terms of the amount of drugs given, what else is prescribed, and allergies. So knowing that we might run out of syringe drivers, we were able to formulate with our colleagues in pharmacy and our end-of-life clinicians different ways of giving these drugs to help patients. Next slide, please. We were able to collate this information in real time in order to help understand where our patients were and what that might mean for service provision. So you can see this is a still taken from our dashboard on the 15th of April. You can also see that it was updated at 2 o'clock. This was happening on a twice daily basis to make sure that our clinicians and our managers within the hospital were working with as much information and as up-to-date information as possible. You could see how many patients had tested positive, how many had tested positive that day, and how many results were pending. And you were also able to click on these numbers and understand where these patients were, making sure that we had appropriate flows through the hospital for suspected, positive, and negative patients. At the bottom of this slide, you can also see that we were able to look at our utilisation of intensive care beds. So we knew how many were used, how many of those patients were positive, and what our bed space capacity was to enable planning and enable us to efficiently open other ITU areas if we needed to. Next slide, please. And this was all brought together across the UHB footprint. And this is a summary that was developed every day. So this is the one published on the 8th of June. We've had one from today as well, which tells us where our hospital is and maps out how we're doing over the course of the COVID crisis. So you can see that there are 4 hospitals that make up UHB: Good Hope, Heartlands, the Queen Elizabeth and Solihull. You can see the number of tested patients to the number of positives and the current positive inpatient burden by age group and gender and by the severity of their symptoms. We were also able to map this against those that had unfortunately lost their lives. And an important piece of planning for us, we were able to map geographically where these patients came from, so we knew if there were any hotspots forming where we could liaise very closely with our colleagues from public health. This proved to be an invaluable tool because we were able to map the number of patients coming through our doors, where they were in the hospital, with the number of nurses and doctors that were available, as this was mapped together with our staffing numbers. So we knew if a ward was going to be low on staff, depending on the need and the severity of the patients housed within them. Next slide, please. In order to inform practice wider, we realised that data from one hospital alone would not be enough. So we've collaborated with the Alan Turing Institute, the University of Birmingham, UCL and UCLH to form DeCover, which combines these sorts of data from high digital maturity trusts, which were hard hit by COVID, to bring them together to answer pressing clinical questions that we may have as we emerge out of this COVID surge and allow us to prepare for the next one if needed. Next slide, please. And so in my last slide, I really wanted to go through what the learnings were from this process. I think the first learning is it's amazing what you can achieve when you have to. COVID-19 has been awful for most of us, but there have been, bizarrely, some benefits. And some of the benefits have been that it's allowed us to think about delivering services in new ways, and it's enabled us to use our electronic health record in ways which inform clinical care in a way that perhaps they haven't before. The rapid use of this accurate health data has definitely supported clinical decision-making on the shop floor, particularly when clinicians were given to areas where perhaps they hadn't worked before and they were unfamiliar with the drugs that would be needed to be prescribed or for caring for those kind of patients. Examples, for example, are rheumatologists working in the acute admissions department beside me. It allowed us to respond to this clinical challenge by making sure our service provision met our service need and to map the pandemic as we flowed through it on a local level. But what this has really highlighted to me are the absolute benefits and need to improve digital maturity of NHS trusts across the country, so that all would have the opportunity to flex this kind of system in place when needed and benefit from it from the long term. Thank you very much.
Thank you very much, Liz. That's perfectly to time. So I'm going to segue directly into Ben. Ben.
Oh, hi there. Thank you for having me. And as always, it's very strange in these troubled times to be speaking to 172 people from a quiet room. So I'm going to talk about OpenSafely, which is a new secure analytics platform that we've built to do electronic health records research during the COVID-19 emergency. OpenSafely.org is now successfully delivering analyses across more than 24 million patients' full pseudonymized primary care NHS health records linked to secondary care data like A&E presentation, death in hospital from COVID, death, test results and so on, with more data to follow shortly. It's an unusual project in that all of our analytics software is fully open for security review, scientific review, and reuse. And OpenSafely uses a new and rather different model for enhanced security and timely access to data. So we don't transport or extract large volumes of potentially disclosive pseudonymized patient data outside of the high security environments where they're already being managed by the electronic health record software vendors. Instead, we've built an analytics platform inside the data center where the records already reside. And we've also built a bespoke trusted research environment. So that brings even greater security and privacy engineering benefits. And it's that pragmatic, secure, but also efficient approach that's allowed us to deliver first analyses across 17 million adults, 24 million people in total, in just 5 weeks from project start. And that's a paper that you can see posted on medRxiv about a month ago, looking at factors associated with death in hospital from COVID in a cohort of 17 million people. So I'd like to talk a little bit about what we've built, about how we've built it, and about what we've learned about the broader system during the coronavirus pandemic. First of all, we set out to build something that could very rapidly and efficiently deliver insights for scientific research, but also for operational research, what's happening where, and also surveillance. We also knew that we needed to achieve something quite new. In particular, we needed to be able to run analyses across unprecedentedly huge numbers of patients' records. And that's for a really important scientific reason. If you want to detect signals like a different risk of death from COVID in small groups of people, for example, people on a medication that's only taken by 100,000 people, if you want to slice demographics up into smaller groups, if you want to slice ethnicity up into smaller groups, and in particular, if you want to look at crossovers of all of the above, then you need to have very, very substantial population coverage, and none of the existing options like CPRD had anything like the scale. But you do need the detailed data on each individual that you get from primary care records. And also we wanted to work very efficiently and very cheaply. So you need to find a place where that data already exists, where you can harness the power of existing administrative data. But we also wanted timely data. One thing that's unusual and very striking about the COVID pandemic is that it came, of course, out of nowhere. And if you're trying to evaluate, for example, factors associated with death from a completely new cause of death, then you cannot rely on the old-fashioned approach of intermittent, very large, and somewhat insecure, but certainly very expensive extracts of data. Instead, you need to have access to data right now. So when we published our first paper, the deaths were still rising. And so if we waited for a 3-month-old or a 6-month-old historic extract, we'd have seen no COVID deaths at all. You also, if you're doing operational research, need signals on what's happening where and quickly. But lastly, we wanted to build something that was fully open and transparent, something that where all of our code was shared for scientific review and also for efficient scientific reuse. Something where all of our code was shared openly and transparently with scientists so that other people could see our code lists and our analyses and see what we were doing. And also where we could be fully transparent to patients, because we certainly all feel very strongly that public engagement shouldn't just be about brief cut down lay summaries. It should be about a full suite of absolute depth of transparency on everything that you're running. However, accessing this kind of huge scale of data requires a radically improved approach to security, because the old models of data extraction are very vulnerable to re-identification attacks. So I suppose a worked example would be if I wanted to identify my wife in a primary care data set, it would be very straightforward. I could just do a SQL query where I looked for somebody who had twins in 2013, another baby in 2014, and where the event codes moved from London to Oxford around about 2015, and then I can identify my wife. Having re-identified my wife in a pseudonymized data set, I could then identify other aspects of her medical record, which she would very reasonably want to be kept confidential. So that, in short, is the privacy issue that we're all always trying to fix. And historically, our approach to that has been to rely on trust. So we say, are the people who are giving these very large data downloads to trustworthy? With OpenSafely, we wanted to go beyond that. We wanted to be able to prove that nothing bad had happened. So All data that carries any privacy risk, even a theoretical risk, and even when pseudonymized, remains within the secure data center of the electronic health record vendor where it already resides. That also means that all activity is logged for independent review. All processing takes place in the same secure data center where the patient's records were already stored, and the only information ever to leave that data center is summary tables. In addition to that, we don't just have a general purpose trusted research environment, something off the shelf, because the problem with those is that even then still, even though you're taking logs, you give people access to do a SQL query with a versatile coding query where they could in theory do a re-identification attack. So instead, we've built a series of layers. If you go and review our code, which is all available at OpenSafely.org, you can see in a lot of detail. But in short, you write code that describes your ideal research cohort. The system then pulls the code lists from our Open Code List service, which has got APIs, works beautifully. Anyone can store their code list there, but more importantly, you can pull them down with an API. It's fully integrated into the analytics framework. And then the system will, first of all, give you test data that you can develop your analytic code against. And then when you're ready to run it against the real data, you push to the live data environment. And the only thing that no researcher is ever allowed to write a SQL query on the event level data set. You can only send in YAML, a markup language, you can send a representation of what your cohort should look like over there. So you get all of the security benefits of only sharing summary data with researchers, but with none of the cost to the precision or convenience of the analyses. Now, the nice side effect of that approach is that everybody who runs any kind of analysis is, if you like, forced by the design of the system to share everything that they produce as they go. So every code list that you produce to describe an exposure variable or an outcome variable is automatically shared on open code lists. All of the cohort characterization code is automatically shared on GitHub. All of the analytic code is automatically shared on GitHub. So this is making it easy to do the right thing. It's openness by design. Let me talk a little bit, just very briefly, about why we made those choices. So first up, we wanted something that would facilitate openness. We also wanted to write open code that was portable. So all of our platform is fully compliant with open standards, designed to be portable. I'm a big fan of NHS Digital's plans for GP data for planning and research, where they're going to make an extraction of all the data into NHS Digital's own environment. Once that's done, we can run OpenSafely against that. We can run OpenSafely indeed against any source of underlying EHR data, and it's all openly available and free for all to use. Let me tell you a little bit about what we learned as we built. So first up, COVID has been a time of great turbulence, but not a time, I think, of anarchy. It's been a time of very overdue, permissive, flexible relationships. It's bringing the A-teams together in lots of different organisations. Everyone's feeling much freer about picking up the phone, and I think it's really fantastic. You know, local authorities find it easy to pick up the phone to hospitals. We've had a lot of incoming direct contact. Everyone will take calls to anyone who's doing good stuff, and that's been great. COVID is bringing better discussions around information governance, and people have become more flexible, but I have to say I don't see anyone becoming reckless yet. If that does happen, I think it's really important to have frank conversations, but as always, the rules with governance are you don't measure its benefits by page length or word count. There are lots of current analytics projects with all the paperwork signed off that I think are much less secure than is ideal, where there are other more secure approaches which would have historically been blocked. And I think we need to have a really judicious rebuild of our approach to software assurance processes and also information governance. One last thing is, we were disappointed and surprised to find that we couldn't find any good open analytics platforms available to reuse. So we evaluated all of the existing software and found nothing that met any of our technical or privacy needs, or at least nothing openly accessible. We found lots of platforms that were publicly funded, but they were inaccessible, undocumented, or didn't quite meet our needs. And And that certainly didn't facilitate efficient open ways of working. And my very strong sense is if we're not allowed to reuse or review someone's publicly funded code and tools without laborious negotiations, then I think that's a real problem for the public purse, but also for patient benefit, because it slows work down. We're here to help. We've got lots of people getting in touch. It's an enormously broad collaboration. It's been built by my team, the Data Lab in Oxford, which is a mixed team of software developers, traditional researchers, and then clinicians, working in collaboration with London School of Hygiene and Tropical Medicine's Electronic Health Records Research Group, also working on behalf of NHS England and NHSX, and also, most importantly, working in collaboration with TPP and other electronic health record platform vendors. And I must say that has been the greatest thing about the whole project. It is nothing short of a love affair. Bringing EHR researchers together with EHR software developers has been an absolute romp. It's been probably the best fun project I think any of us have ever worked on. So I'll stop there.
Thank you, Ben, and thank you for making those points and sharing the idea of romping with the electronic healthcare record providers. On that note, I'll pass on to Sue Mason to give the third and final talk. Thanks, Sue.
Thank you, Simon. Hello, everyone. I'm going to talk a little bit more about the value of using routine data and contextualize that in COVID-19, but also to talk about how important it is that we look at data across boundaries, and both Liz and Ben have talked a little bit about this, and Liz particularly talked about the urgent care aspects of data acquisition and linkage. So I'm not going to labour that, but that's my particular area of interest. And a lot of what we've done has been on the background of understanding that patients don't see their journey in the context of one interaction with a healthcare provider, but they see it across boundaries of care, where they may call an ambulance or NHS 111, go to the A&E department, and then be admitted to hospital, and then be discharged into their home or to another facility. And we need to be able to gather data and link it together to be able to describe and understand that whole journey for patients, in order to understand where we can intervene, how timely that could be, in order to both to shorten their journey, but also to improve outcomes. So much of my work has been around gathering routine data from urgent and emergency care settings, linking that together for a region in the north, Yorkshire and the Humber, for a population of 5.6 million people. However, more recently, we have been looking at the impact of COVID, and on the back of us gaining funding to become an HDR UK partnership in the north, we have been looking at the challenges that we have with the care home population. Next slide, please. So we all have heard in the media and read about the difficulties that care homes have had faced with the pandemic. Largely this came out of left field, whereby initially older people were thought not to be adversely affected in care homes, and the guidance therefore was very late in catching up with what care homes needed to do to try and mitigate the effects of COVID. And therefore we saw problems arising and responded to that rather in a late way. Next slide, please. So this is Public Health England data, which shows you how care homes were affected from before the lockdown through to right through to the beginning of June. You know, we're all familiar with this kind of pattern now, and we can see that there was this problem with huge numbers of homes having outbreaks. Some of these outbreaks would have been very small, where there may have been only 1 or 2 residents affected, but some of them were very large. Next slide, please. When Public Health England started to look at the data, they have identified that almost 50% of all care homes, that's residential and nursing, were affected by a COVID outbreak of some description. And not surprisingly, this was affected by the size of the care home. So the larger the care home, the more likely they were to have a COVID outbreak, and the larger number of patients were residents were affected by that, but also by the type of care home, with the frail and more sick patients who resided in nursing homes and dementia care homes were affected much more adversely than in residential homes. So this led to a lot of questions that we have been trying to address through a subcommittee formed by SAGE, because there clearly is a problem here where we're not addressing the outbreak, where some care homes have managed it very well and some care homes have not managed it so well, and what are the differences there, and how can we address that in the future? How can we reduce the number of outbreaks, but also limit the extent of the outbreak within care homes? And the SAGE subcommittee that I've been part of has very much been focusing on those areas where there is a lack of evidence and not enough research done, and how can we address that through organisations like our HDR UK Conference. Next slide, please. And you can see from this analysis that's been done from care home residents in the North East that, you know, not surprisingly, survival patterns amongst care home residents was much worse than non-care home residents. So even when admitted to hospital, and we know that many of them were not admitted to hospital, but when they did come into hospital, survival was significantly worse, and the length of time that they survived for from in care home residents was much reduced compared to non-care home residents. Next slide, please. So our HDR UK project that we originally set out to do and have been slightly diverted now onto in relation to COVID is around looking at linking data from care homes to understand patient journeys when they're becoming well in a care home and what happens subsequently. This has largely arisen out of the fact that many care homes now are starting to collect digital data, and one of the examples here is a care home app where the care home staff collect information on their residents, which involves recording a News2 score and also making referrals where that's needed, and the resident may have become unwell, to a GP hub. The referral is very structured in the form of an S-bar, and the care home staff are trained to take observations on residents so that a News2 score can be calculated. The information then is linked through to a community hub where staff can triage that information and make an appropriate referral for that resident, which may range from a district nurse going out to see the resident right through to an ambulance being called and the resident being taken to hospital. The idea is this will expedite an action on the unwell resident, and that it would also allow staff to have a slightly more confidence in the referrals that they're making. So we'd originally set out to do the analysis on this app, which then links through to hospital data so that we get data on each of those residents when they go to A&E, when they are admitted to hospital, and when they're discharged again. And then COVID obviously has got somewhat in the way and has presented us as with a new opportunity to use this linked data set and evaluate the impact that COVID-19 has had on our care homes within the data. At the moment, around 120 care homes are using this particular app, but there are a number of care homes within the North East that are using different types of digital information. Next slide, please. Just to give you a little bit of background on how care homes are using the News score at the moment, colleagues within the team who we're working with have published recently to look at the ability of care home staff to record News score. Many of you will know that care home staff generally often don't take obs on patients. They're not trained to do that, and so this is a whole new skill for them. And really, how well do they adapt to taking observations on their residents and then using that in order to make clinical decisions on them? You can see here from this paper that was published that Barbara Hanratty and colleagues looked at using the News2 score as a way of identifying acute illness in their residents in care homes, and found that overall News scores are low, but that it provided the staff with a way of communicating the needs of their residents better. It gave them increased confidence in being able to respond to a change in their illness condition in a more timely way. But equally, there were problems with training staff in terms of them having competing priorities and also in adapting to taking observations from patients. Next slide, please. The same team have also looked at the use of the news score and the ability for it to help in identifying COVID deaths. So this is a linked data set where news score was linked to resident demographics and also to ONS, or cause mortality. And here you can see on the right hand side that the news score was going up prior to the rise in all-cause mortality, which is COVID and non-COVID deaths. This is in just under 500 care homes. And that this became a useful way of predicting a likely increase in COVID deaths and illness. What the team found was that actually not all the parameters within news were useful, and actually the most useful parameters were oxygen, respiratory rate and temperature measurement, which on the bottom graphic you will see were highly active with a 2-week lag of a rise in COVID and non-COVID related deaths within care homes. And therefore this could be used as a useful tool for populations and particularly care home populations to identify the likelihood of residents contracting COVID. Next slide, please. So what are we going to do next? Well, the SAGE subcommittee identified a number of problems that we are going to be able to address within an IHR bid that we have just submitted for funding. And this is really about understanding the issue around residents being transferred in and out of care homes and into secondary care settings, and to what extent this leads to problems for care homes when they're discharged again, to what extent it actually improves outcomes for residents or not, and to what extent there is a variation between different types of care homes in terms of how those residents are managed, and trying to look at optimum management strategies for both the individual residents but also for the care homes to manage their outbreaks and reduce the impact of the likelihood that the residents are coming back and bringing in COVID from outside. Final slide. Thank you for your attention. I'm very happy to answer questions, or my email and Twitter handles are there if you want to get in touch with me. Thank you.
So thank you, Sue. Thank you to all of the speakers. I think fantastic examples of breadth, depth, and certainly pace over the last few months in terms of delivering all of this. So I seem to have lost some of the questions, in fact, but I'm going to work my way up from the bottom, Alistair, for your information. The first question that I'd like to ask is to Sue. This is from Elizabeth Lemon, which is, do you have any data to identify those receiving care in the community, i.e. at home and not in a care home?
Not currently. So it's quite difficult to identify an older person who's receiving community care. We can identify care home residents quite easily from data using algorithms, for example. However, we do work quite closely with local authorities in the Northeast, and so you know, it may well be in due course we will be able to get to that point where we can identify residents who are cared for in their own home. Thank you. Alistair?
And Sue, question from your fellow speaker, Ben. So are any of the data you presented, is this yet available in the public domain on preprint servers and so on for further reading?
Sorry, no, this is, so this is a project that literally we only got our funding 6 weeks ago. So we're very much getting to grips with corralling our data for the purposes of research, so developing our sharing further so that we can share across our own partnership, HDR partnership, and then what we were looking to is a wider sharing of that in due course. using other colleagues, for example, working with SAIL, who may be able to assist us with that rather more a collaborative approach to using the data.
Thank you, Sue.
Thank you. One that I remember that I seem to have lost was around defining COVID-19, Liz. It was around, what did you do with the PCR negative patients?
Yes, thank you. So like all tests, they have to be interpreted with the clinical findings firmly in your mind. And so if a patient was considered to still be suspected of having COVID despite a negative test, they would be labelled still as suspected, carried through the system as such, and re-swabbed to see if that gave us a better result. But our clinical acumen for that, particularly if they had classical chest X-ray and CT findings, always held more sway than a test result.
So, Liz, still with you, but this is a question for you and then for Ben, was from Hilary Fanning. May I ask about patient and public involvement engagement in these initiatives, and what's the plan for persistence post-term of COPE notice? So you might just want to unpack COPE very briefly as well.
Brilliant. Should I start? Should I do the easy bit and then hand over to the difficult bit for Ben?
Yeah.
So in terms of patient and public involvement, that's crucial to how all of the hubs operate. So we've spoken to now well over 450 individuals about the use of health data with acute care in mind, and then specifically with COVID, and have a patient and public group embedded in all of our decision making through a data trust committee that reviews all of our data access requests as part of DeCover and Pioneer, and to support our decision making. That's been vital for us, that transparency. And for DeCover, if you look at www.decover.org, you'll see our protocol freely available for anyone to review, with our patient and public structure and strategy embedded within it. So if anyone would like to look at that, they're really welcome to. In terms of COPE, that was a directive that came from the Department of Health, suggesting that during the COVID pandemic, because of the huge crisis and challenge that this posed, patients who would normally, or who may have opted out using the NHS digital opt-out, their data could remain in the system for health and research purposes. For our running strategies, we are still looking at the opt-out for NHS digital, and post COPE directive, we will go back to the usual way of working, which is that anybody who's opted out will not have their data put into the data safe haven in order to so that's our say on it. Ben.
Yeah, so in terms of our approach to PPIE, I always think there's a missing P in that phrase. It should be patient, public and professional engagement and involvement. It's important to reflect that not all clinicians are expert computational data scientists. In fact, a lot of researchers have got a great deal of very deep vertical knowledge in one tiny silo where they work. So I think it's important for all of us to follow best practice in sharing an enormous amount of detail with everything that we do to all of those around us. So first up, we share everything as preprints as we go so that people can see the results of our studies as quickly as possible. I think that's really important during a global health emergency, but I think it's also important at all times. It allows the public to see exactly what we're doing in detail, but it also allows other collaborators, other people who are working on similar questions, to know what the important knowledge gaps are, where they can help, without relying on kind of behind the scenes coordination and that kind of stricter directed collaboration. We also share all of our code, which I think is really, really important for just absolutely full, robust transparency. So we do have the traditional PPIE stuff. We have things written on the website describing the project. You can drill down to all the details, but I think it's really important to make sure that you get everything out there and accessible to everyone, rather than withholding code lists, withholding analytic code, and so on. The last thing I would say is we have great plans around more elaborate patient and public involvement, and that's something which I've done a lot of in the past, writing books and doing TED Talks and so on. I should say OpenSafely is not an HDR UK funded project, despite our best efforts, and it also in fact had no funding at all up until 4 days ago when we got an award notice from UKRI. So we're really just at the beginning of being able to build out from there. But everything that you see with OpenSafely, the analytics platform running across 24.2 million patients' data, the paper outputs, the code, that's all been written and produced by people working, in some cases, as entirely unpaid volunteers, and in other cases, just people volunteering in their time from other research projects. And as soon as we have funding, there will be an explosion of patient engagement like no other.
Thank you, Ben, and thank you for absolutely, as Ben knows, probably or may know, that third P is in fact being added in by HDR UK in all future events. So that's a really important point. So there's quite a lot of in common here across some of the questions, but I'm just going to ask, great talk. This is to Ben. I may have missed it, but how does OpenSafely deal with aggregation of data sets from, say, different trusts, GP practices, or indeed social care? Or does it rely on having all data under one roof?
Yeah, so I think this is a really important issue. It's about if you collaborate widely outside of the kind of traditional academic perimeter, as we do with EHR vendors, then you get an understanding of how the landscape of data flows in the NHS is operating in its normal state. So that's how we knew that all of the EHR data for TPP patients was held in one data center. And so that's how we knew that that was an efficient move to go and build the analytics platform in that setting. So there's no aggregation required there. I'm really interested from a very kind of abstract, pointy-headed perspective in federated analyses, where you do analyses where the exposure and the outcome data are all held, the same patient's exposure and outcome data is in the same place, but small pockets of it in individual trusts. We evaluated some of the existing libraries for that, and none of them did survival analysis, but we've got plans in place to build out that approach with OpenSafely to run across more segregated data sets, which I'm really looking forward to.
So I'm conscious of the fact that it's we have 3 minutes to go now, so I'm going to hand over to Alistair actually to wrap up.
So, well, thank you to all the speakers and for really interesting series of presentations, and actually also the discussion around it. So thank you to all those who sent questions in, and my apologies to those we didn't get time for on this. I mean, I was struck just in sort of concluding remarks. I think there's some common themes that have come through. I think I really liked Ben's phrase, time of turmoil, but not of anarchy. I think that is absolutely nailed it. I think there's clearly across all the conversation here, there's been a theme of breaking down barriers, real emphasis on transparency and the different ways that this has been demonstrated, both in terms of to the wider public, to colleagues, the kind of publication early, not waiting till everything is completely nailed down, but sort of sharing the journey and being open to scrutiny on that. And then benefiting from the input of others. So the idea of just that people are in this era more ready to pick up the phone because there's a common emergency to deal with, and working together. I think there's really striking examples how most of the slides with data were kind of dated within the last fortnight, and this kind of the fact that we're now using data in a live way to both literally live as we're with the patient in front of us, as illustrated in some of Liz's slides, but also how that is then informing decision making at a kind of slightly more aggregated level, whether in primary care, whether in the care homes sector or in secondary care or at policy level, and the way this has been feeding in from organisations such as represented here and from HDR UK to decision-making bodies like SAGE. So I think there's been some really exciting themes coming through. I think we've seen here, which is a key better care theme, how data can be informing both quality care delivery live and research and kind of discovery and innovation. And I think this has really been accelerated in this period and nicely demonstrated here. So Finally, just thanks again to all those who put presentations together and such an interesting session. And thanks to you all for taking part.